This lecture will be on Chapter 17, Defects of Plasma Clotting Factors. At the end of this lecture, the student will be able to describe the variable types of bleeding found in patients with clotting factor deficiencies versus platelet disorders, define the factor VIII molecule, outline the genetics of the hemophilia disorders, describe the role of vitamin K with regard to maintaining hemostasis, summarize the symptoms and laboratory results in individuals with hemophilia A and hemophilia B, describe the management and treatment of individuals with hemophilia A and hemophilia B, distinguish the clotting factor disorders with little or no bleeding, and lastly, describe the types of bleeding secondary to a chronic disease process. Plasma clotting factors are inactive enzymes that are activated by an injury. So when these when these enzymes are poorly made, or if they're mutated, or there's something impaired with their functionality, it leads to issues with the hemostasis process. Because of that, we have issues known as hemophilias, and hemophilias represent any group of disorders in which a particular clotting factor is decreased. So we have hemophilia A, which is a factor VIII deficiency. We also have hemophilia B, which is a factor IX deficiency. Both hemophilia A and hemophilia B are sex-linked recessive disorders. Factor VIII is unique in a couple of different ways. One of the ways it is unique is that it is the only clotting factor that's synthesized in the liver. It's genetically controlled by the X chromosome, and it also forms a complex with the von Willebrand factor, which transport it into circulation. The von Willebrand factor is labile, meaning it is easily altered, and because of that it is unstable in stored plasma. So the von Willebrand factor is normal with hemophilia A, but because the APTT, or activated partial thromboplastin time, is abnormal, is due to the reduced level of the factor VIII. Here you can see a diagram of the factor VIII complex, where you have the anti-hemophilic factor that comes from the X chromosome with the von Willebrand factor monomers that become a polymer, and those two things are conjoined here. You can see where the AHF and the von Willebrand factor form a unit, and that's the factor VIII complex. When it comes to the measurement of clotting factors, we look at the percent activity. Most clotting factors need to be available in the body at a minimum of 30% to achieve hemostasis. We also look at the function in our coagulation testing. There are 3 levels of clotting factor activity in hemophilia. With severe hemophilia, it's going to be less than 1%, moderate hemophilia 1 to 5%, and mild hemophilia is 6 to 24%. Hemophilia A symptoms can include circumcisional bleeds, which means when a male infant about 7 to 8 days old has the foreskin removed. That can cause a bleed, an indication that there is a problem with hemophilia, or umbilical cord bleeding when the umbilical cord is cut or removed from the newborn. There can also be issues with crawling, walking, or running. May present certain challenges for the patient. There may be bleeding in other areas of the body, such as the GI tract or the gastrointestinal tract, in the kidneys, the gums, or even in hematomas, which are like bruises. There might be muscle or joint bleeds, and there may also be intracranial bleeding, which means there's actually bleeding above the brain. When a physician is looking into a possible bleeding disorder, there are several things they look at. They're going to look at patient history, they're going to do a physical exam, laboratory testing, which is what our job will be of running those tests, looking at any type of family bleeding history, whether it's open bleeds or closed bleeds, All of those things are going to come into consideration when the physician is trying to evaluate if the patient in fact does have a bleeding disorder. The difference between open bleeding and closed bleeding, you can see here we have a list of those different types. So with open bleeding, you can have bleeding with your tongue, your tonsils, your gums, nosebleeds, heavy menstrual bleeding. Again, we mentioned the umbilical cord, which obviously would only be applicable to a newborn type situation. Circumcisional, which, as before I mentioned, the foreskin is being removed on male infants. Closed bleeding is going to be more akin to issues with bleeding when it comes to soft tissue, your genitourinary tract, gastrointestinal bleeds, bleeding in the muscles, bleeding in the bones, joints, and even the skull. When it comes to hemophilia A laboratory diagnosis, the tests that would be ran and the expected results would be that the PT is normal, the APTT would be increased, the patient would have a normal von Willebrand factor. You would also run single factor assays, and that's going to be performed by using the APTT testing. The patient's plasma is going to be mixed with commercially prepared factor deficient plasma in 1:10 ratios, and if the APTT remains abnormal, it signifies that the patient is actually missing that factor 8. If the APTT is normal, that means the patient sample supplied the missing factor to the commercially available factor deficient plasma. And so all this, the APTT is going to be plotted on the factor activity curve. So previously, or in the earlier days, patients with hemophilia A were treated with transfused pooled cryoprecipitate. And unfortunately, prior to 1985, with this product being used, which is it's a pulled plasma pulled from a donor pool that has the factor concentrates within that. They were not screened for the HIV virus, and unfortunately 80 to 90% of hemophilia A patients contracted the HIV virus, as well as other viruses, probably hepatitis B, hepatitis C. The cryoprecipitate is a good treatment when it has been properly screened for communicable diseases, because it contains fibrinogen, the factor 8, which is what they're missing, and the von Willebrand factor. There are other products that can be used that are not human-derived, meaning you don't have to worry about them being screened from donors or any type of virus that can be passed along to the recipient. They're known as recombinant products, which means they are genetically engineered clones of the factor 8. The only issue with this is that it's very costly for the manufacturer to produce, and those costs are passed along to the patient in order to receive that type of treatment. Those products became available around 1992. Previously, there was also the viral vector, which I'm going to speak about on the next slide. In 1987, there was more work done into gene therapy, where factor 8 is actually inserted into a virus vector. Then the virus vector is actually lodged into the body of the patient so it can produce the factor 8 for them. There are complications with this because the body can reject that virus vector and cause those complications. This is still a therapy that is being worked on, and they feel like this type of gene therapy can be very beneficial to the patient. There are just some things that still need to be worked out. There are a few quality of life issues for patients who have hemophilia A. Hospital visits for children can become very costly after episodes. I think the book references a minimum of $50,000 a year spent on these episodes of having to be treated at the hospital. Feelings of isolation, anger, or disappointment due to the diagnosis and all the complications that it provides in the patient's life. As I mentioned before, the recombinant or high purity infusible factor is expensive because it's expensive to produce. It's therefore expensive for the patient. And due to the hemophilia, there can often be viral infections that are missed within the patient, and therefore it can lead to liver damage that the patient may not be aware of until the damage has already occurred. For patients with hemophilia A, they may develop factor VIII inhibitors. These inhibitors are dependent upon time and temperature. It develops in 15 to 20% of individuals who have hemophilia A. This is occurring because the patient develops autoantibodies against the factor VIII, and it starts to neutralize the factor VIII coagulation portion. So some treatment options when this is the case, when the inhibitor is low titered, the patient may be infused with the appropriate level of factor VIII to try to neutralize that inhibitor. If that does not work, or it's considered ineffective, they can use a factor substitute or porcine factor VIII. Porcine meaning it is related to swine or pigs. And there's also alternative therapies such as anti-inhibitor coagulation complex that could be tried. The next type of hemophilia we're going to discuss is hemophilia B, also known as Christmas disease. Hemophilia B accounts for 10% of all patients who have hemophilia. Hemophilia B is caused by factor IX deficiency. The inheritance, clinical symptoms, laboratory diagnosis, and complications are all the same as hemophilia A. We have a prolonged APTT, and there is decreased factor SA activity. The treatment for hemophilia B consists of factor IX concentrates, trying to replace that missing factor. You can also use a prothrombin complex, which is a mix of factors 2, 7, 9, and 10. There are also some newer recombinant therapies that have the factor IX in them that can be used. Those names specifically are in your textbook if you want to refer to those, but just know that recombinant factor IX products are available to treat hemophilia B. Congenital factor deficiencies with bleeding manifestations are patients that are having deficiencies of factors 2, 5, 7, and 10, which are all rare. They're autosomal recessive. The types of bleeds that may occur with these factor deficiencies are skin and mucous membranes, and occasionally with the joints and knees. Treatment for this type of deficiency would be prothrombin complex concentrates. Continuing with congenital factor deficiencies with bleeding manifestations, we have prothrombin factor II deficiency. This can cause dysproteinemia, which means there's a variation in the types of concentrations of proteins that are in the blood. The mutation is in the prothrombin gene that predisposes an individual to venous thrombosis, meaning clotting in the veins. We also have factor V Leiden. The mutation is at the 506 position of the factor V gene. It impedes degradation of the factor V by protein C, causing activated protein C resistance. It leads to increased clot formation with subsequent DVT, which is deep vein thrombosis, and hypercoagulability conditions. So these congenital factor deficiencies are concerned with issues with contact activation and clot stabilization. They affect factors such as factors 11, 12, Fletcher, and Fitzgerald. The bleeding is unlikely unless a trauma occurs, and there is no direct correlation between the deficiency of the factor and the bleeding episode. The factor 12 deficiency is an autosomal recessive trait in which there is a prolonged APTT in laboratory testing, and the patients are prone to thrombosis or clot formation as an indicator. So again, with the congenital factor deficiencies, we have the factor 12 deficiency, where we would see a prolonged APTT in the laboratory testing portion, where thrombosis or clot formation does occur. We also have Fletcher or pre-kallikrein deficiency, which is autosomal dominant and recessive trait. The patient may have thrombotic events such as an MI, which is a myocardial infarction, otherwise known as a heart attack, or even pulmonary embolism, which is a blood clot within the lung. We also have Fitzgerald or HMWK deficiency. HMWK is high molecular weight kininogen. This is a rare autosomal recessive condition, and this particular deficiency may cause DVT or deep vein thrombosis or pulmonary embolism, as I just mentioned, which is a blood clot that forms in the lung. Continuing with congenital factor deficiencies, where bleeding is mild or even absent, we have the factor 13 deficiency, which is considered to be a rare autosomal disorder. Symptoms of this deficiency may be poor wound healing, meaning the wound is not healing as fast or as well as it could be. Keloid formation. A keloid is a scar that forms at the site of an injury that appears to have a rubbery consistency or a shiny surface. It's usually elevated. Also spontaneous abortion, which is otherwise known as a miscarriage, or even recurrent hematomas. With the factor 13 deficiency, the patient will have a normal PT and a normal APTT. So in order to further determine if factor 13 deficiency is a problem, there's a screening test called the 5 moles per milliliter urea test. The 5 moles per milliliter urea test measures the stability or the firmness of a clot after 24 hours in a 5 moles per liter urea solution. So after this 24-hour period, if the clot is that has been put into the solution is stringy or loose versus firm, which is what a normal clot should feel like, it shows that the factor 13 is decreased. Also, there are quantitative assays available for checking for factor 13. Factor 13 deficiency treatment can include fresh frozen plasma or FFP. The FFP has all the clotting factors. Cryoprecipitate may be used, which has fibrinogen. Specific clotting factors like factor 8, factor 13, the von Willebrand's factor, and fibronectin. There are acquired deficiencies of factor 13 that may be associated with such disease states as Crohn's disease, leukemias, DIC, which is disseminated intravascular coagulation, and also ulcerative colitis. Here is a chart that gives you kind of each factor with when it comes to inherited clotting factor defects. So you can see here at the top, it's listed your clotting factor, your PT test results, your PTT test results, and types of bleeding or other findings. So with factor 2, the PT and PTT is increased. Particular things or findings in factor 2 deficiency would be skin or mucous membrane bleeding. Factor 5, increased PT and PTT with infrequent bleeding. Factor 7, an increased PT, a normal or not abnormal PTT that also occurs with infrequent bleeding. Factor 8 deficiency, we have a normal PT, an increased PTT. Hemarthrosis, which means there's bleeding in the joints. Circumcisional bleeds, hematomas, intracranial bleeding, as we discussed several of these symptoms in previous slides on this lecture. Factor 9, you're going to have a normal PT, an increased PTT, as above, meaning the same as factor 8. Factor 10, an increased PT, an increased PTT, infrequent bleeding. And factor 11, a normal PT, an increased PTT result, and that is associated with infrequent bleeding. For factor 13 that we just discussed, you're going to have a normal PT, a normal or not abnormal PTT. Symptoms may include poor wound healing, keloids, or spontaneous abortion. Fletcher factor, normal PT, increased PTT, and the patient may have thrombotic episodes, which meaning it may happen due to circumstantial things, but not a regular occurrence in their lives. The same with the Fitzgerald factor. And again, on factor 13, you can use the 5-mole urea test to check for the integrity of the clot formation. There are also patients that can have bleeding that is secondary to a chronic disease process. So there are deficiencies to the clotting factors that may be related to liver disease, renal disease, which is kidney disease, or some sort of autoimmune process. Conditions that affect the clotting factor production and function may be things such as alcoholic cirrhosis, which that is tied to the liver, biliary cancer, also tied to the liver, congenital liver defects, meaning there's some sort of issue from birth with the liver, obstructive liver disease, and hepatitis. Treatment for patients with liver disease who are bleeding, they can be treated with fresh frozen plasma as a way to get them the clotting factors that they may need. 15 milliliters of plasma can increase the clotting factor activity by 15 to 25%, so that's a significant increase for the patient. Patients with renal disease are cautioned against taking aspirin or platelet inhibitors so it doesn't further exacerbate whatever is happening secondary from their renal disease to some sort of bleeding process. Vitamin K plays a role in hemostasis. So vitamin K is a fat-soluble vitamin that's necessary for factors 2, factor 7, factor 9, and factor 10. We take in vitamin K by our diet in the form of green leafy vegetables, fish, soybeans, canola, and olive oils. Vitamin K is also synthesized by our intestinal flora. Specifically, it can be tied to Bacteroides fragilis and E. coli. You might be familiar with both of those, or at least the E. coli that you'll learn about in micro. When it comes to the role of vitamin K in hemostasis, there are vitamin K dependent factors. The activation of the vitamin K requires a second carboxyl group through the enzyme gamma-glutamyl carboxylase. This reaction requires the vitamin K, and once this is activated, those factors can bind to the calcium and then to the phospholipids. Vitamin K deficiency may occur due to dietary deficiency. We just talked about how we eat certain foods that provide vitamin K to the body, long-term antibiotic therapy, chronic diarrhea, biliary atresia. The biliary atresia is a condition in infants in which the bile ducts outside and inside the liver are scarred and therefore blocked. Alcoholism or other liver problems because bile salts are needed for the vitamin K absorption. Patients that are having to be treated with warfarin or Coumadin, which is a pharmaceutical medication, is actually a vitamin K antagonist, and that's how that medication works. If vitamin K is depleted, you will have an increased PT and PTT time, but it can be corrected by the normal plasma. Factor assays of the specific vitamin K factors will reveal a depressed activity.